and welcome to this session. I'm here today with our guest, Dr. Leigh Bishop, who is a staff psychiatrist in Houston with our returning troops. And Dr. Bishop, Leigh, it's great to have you with us. And today we're going to be talking about assessment and treatment protocols, specifically as it relates to the military, our veterans, our returning troops. So let's start with the assessment side of the equation. As you think about what you do as a staff psychiatrist and your team there in the VA center, what would you say are the critical core issues that you must take into account as you're assessing your patients?
Well, I think first of all, we want to get a good sense of specific describable symptoms that the individual presents. It's only with a clear understanding of those symptoms that we can really make a diagnosis, whether of PTSD or depression or some other form of anxiety or mood disorder, or perhaps if there's substance abuse involved, being able to make that sort of diagnosis as well. So it's very important at the outset to facilitate the individual in describing what their experience is. Sometimes that involves also talking to people around the individual, family members who can oftentimes provide information based on their observation that the veteran or the service member themselves may not have been aware of. Particularly, for example, taking one example, sleep is a very important issue, and very often spouses can tell us something about the sleep behavior that, of course, the veteran often or the service member often cannot be aware of themselves.
I imagine it could either be a lack of awareness, or in some cases it might just be denial, not wanting to acknowledge that a person is struggling with a particular set of symptoms.
That's often very true. Very often the service member or veteran doesn't realize, for example, how their irritability and difficulty in managing anger, which often is one of the real changes that family members and friends pick up when they've returned from the combat zone, they often themselves don't realize that it's affecting people around them in the way that it is. And getting that feedback from family members, sometimes from friends or associates, can be very helpful.
I suppose, in one sense, it's difficult to extinguish or resolve a treatment issue until you can distinguish or identify that issue.
Well, that's absolutely true. Right. You know, the old rule in all of medicine is you can't effectively treat something if you don't know what that something is.
Right.
Diagnosis has to come first. You have to make as accurate a diagnosis as you can, and then the treatment, then, while it may not altogether be obvious, it certainly is going to be much more on track than if you start out with a wrong diagnosis to begin with.
And as you think about the combat trauma spectrum, because there will be a continuum of symptoms leading to more severe end of the diagnostic scale, how important is it that you identify where that person is along that spectrum, on that continuum? How does that relate to eventual treatment decisions that you'll make as a team?
Well, as they're at the milder end of the spectrum, then as common sense might dictate, one might not have to involve as many of the more intensive and frequent clinical encounters with that individual to successfully treat the disorder. With more intense symptoms, with more of the symptoms of a given disorder, say of post-traumatic stress disorder, then very often that may indicate a more comprehensive and more intensive approach to treatment. For instance, with milder PTSD and depression, we may see those individuals on a once every couple of weeks basis for some psychotherapy. I may see them once every 3 to 4 weeks for a medication check.
Right.
But individuals who are having much more intensive kinds of symptoms, having difficulty functioning on a day-to-day basis, going to work, relating to family members in the way that they want to and need to, those individuals may need to be involved in sessions multiple times a week.
So how common is it to see, as you're making this assessment along the scale, to see suicide potential or risk? I would think that that would be one of the things that would be a marker for you, that you would specifically look for in people you might suspect of having PTSD or are returning veterans that are coming back.
Certainly, the safety of the individual is a priority, and so one of the first things that we want to do at the very outset is to get some sense of whether that individual is a risk to themselves. Either because they're having an actual suicidal crisis with a plan, or perhaps just someone who feels like that they have lost the purpose for living and maybe haven't even thought of suicide in a serious way, but nevertheless is having those thoughts. So we want to assess that at the outset and get a sense of how high the risk is for harm to self, and do what we need to do to make sure that individual is safe.